So the first thing that community oncologists want to know is, what are menin inhibitors? We are all a little pleased with the recent approval of revumenib, the first menin inhibitor, first-in-class agent for patients with relapsed and refractory KMT2A rearranged acute leukemias. However, this particular ASH featured an entire session of 6 oral abstracts focused on studies with menin inhibitors. Long-term follow-up of the Augment 101 showing the long-term results of revumenib continuing to show benefit in up to 2/3 of patients, but a CR rate of only about 15%. What I think was a real highlight of that section was the combination data and the emergence of 2 newer menin inhibitors, Bleximenib and Enzomenib. So the data with combination studies, we saw revumenib combined with ven-aza in the relapsed refractory, not ven-aza, but ven oral decitabine, the SAVE study, and significantly improved overall response rates, 70 to 80% when you combine ven-aza with revu in relapsed disease. We also saw response rates of 100% with the combination of another menin inhibitor, ziftomenib, plus 7 and 3 in patients with NPM1 mutant disease, newly diagnosed with some adverse characteristics. 24 to 24 patients achieving a full CR with count recovery. Everybody still alive after that therapy. Patients with KMT2A doing a little less well, but still extremely impressive. And that data was reflected in data with Bleximenib, one of the other menin inhibitors, again, slightly lower response rates, CR rates, but again, showing the benefit of menin inhibition plus 7 and 3. So a highlight of this year's ASH would be to look for the further development of menin inhibitors. Revumenib now available for KMT2A. We're looking for menin inhibitors to be approved in NPM1 mutant disease, which is the second subtype, and combination 7 and 3 looks great, awesome, asking us a lot of questions, what we're doing with our NPM1 patients, should we be doing FLT3 inhibition for those patients, should we be doing transplant, and in combination with ven-aza. Other studies looking at gilteritinib, we have quizartinib and midostaurin, 7+3 for FLT3 mutant, newly diagnosed younger fit patients. What about GILT? How about moving GILT from relapse to upfront? So the results of the PRECOG study, which is a randomized phase 2 done by the groups in the United States, looked at the combination of GILT 7+3 as opposed to 7+3 alone. Their primary endpoint was MRD negative CR after induction, and data presented by Luger and colleagues today demonstrated that there was no difference in the MRD negative CR after 1 cycle. Now, the endpoint is a little deceiving when you look further along after consolidation. When you look at MRD negative CR rates further along therapy, they actually show a significant difference. But for that trial, the primary endpoint was negative. We saw uproleselan, the glycomimetics, E-selectin agent, phase 3 randomized data in the relapsed refractory setting that showed no significant difference. So like that drug looks like it's not moving forward. We saw some new data with CPX showing that the subsets of secondary mutations that would predict for response with CPX. And we saw some data in secondary AML showing the superiority in a randomized phase 3 CPX over flag for those patients. And that harkens back to our abstract retrospectively showing secondary MDS hypomethylation benefit from intensive therapy. So a lot of exciting data, precision medicine data, the advent of menin inhibitors. These are all things we're looking forward to take from San Diego this year from ASH.